Thank you for joining us for OrthoAlliance's OrthoInsights educational webinar series on overcoming arthritis. Tonight's speakers are Drs. Wesley Lackey, Zackary Byrd, Robert Rolf, and Terrence Philbin. In addition to our OrthoAlliance physicians, Sandy Messner, Executive Director for the Indiana Arthritis Foundation, will be speaking about what arthritis is and the many tools the Arthritis Foundation has to help patients navigate this disease. Speakers will answer questions following the presentations. Please type your questions in the Q&A box at the bottom of your screen. We will include all questions and answers on our OrthoInsights webinar series blog located on the OrthoAlliance website at orthoalliance.com. At this time, I'll turn it over to Sandy from the Arthritis Foundation.
Hi, everybody. My name is Sandy Messner, and I am the Executive Director here in Indiana at the Arthritis Foundation. The Arthritis Foundation is a national nonprofit organization, and we're dedicated to helping people with arthritis live their best lives. And we do that through investment in science to find treatments and a cure, also patient support and advocacy. For my part of today's presentation, I'll provide some really basic information about arthritis, and then I'll spend just a little bit of time talking about some Arthritis Foundation resources that are free and they're available to anyone at any time. I'll also share contact information for the Arthritis Foundation staff in your local area because we welcome your questions and your emails and your calls at any time. So what is arthritis? Basically, knees, hips, shoulders, elbows, these are all examples of joints. They're parts of the body where two bones meet and they move. The word arthritis is a medical term that literally means joint inflammation, but arthritis also refers to a group of over 100 different diseases. Arthritis affects not only joints, but sometimes other parts of the body like the skin or the organs or the tissues around a joint. So now let's talk some about the facts and the figures of arthritis. This slide says it all about why we exist. Because 1 in 4 Americans has arthritis, and that's more than 60 million people, including 300,000 children, which makes it the #1 cause of disability. Let's think about that for a minute. As the #1 cause of disability, arthritis is far-reaching and it really affects everybody. It's also expensive, it threatens quality of life, and we at the Arthritis Foundation are making a difference in the lives of people with arthritis, and we're helping to save millions of dollars in healthcare costs. There's over 100 types of arthritis, but we don't have enough time to talk about all of them today. So today we'll mostly focus on the first type, which is arthritis, osteoarthritis, which is a type of wear and tear arthritis. And the doctors on this call are going to provide you with great information about treatment. Gout is also another one that people have heard of. There's also many different autoimmune and inflammatory forms of arthritis. Even children get arthritis, which is something that a lot of people don't realize. So juvenile arthritis is an autoimmune form that affects hundreds of thousands of kids. If you have questions about these or other types of arthritis, the Arthritis Foundation can provide you with information and resources. I'm going to give you our contact information for your local arthritis rep, but also our website is a really great source of information. And then I want to share with you our resources. We have lots of different ways that we support patients and that we can give patients access to community. And one of those ways is through volunteering. We have event volunteers that help plan and execute events. We have mission volunteers. We have local and national opportunities. And the Arthritis Foundation is really a volunteer-powered organization. We also do a lot with community connections. For instance, we have conferences, we have connect groups that people can join that are topic-based, demographic-based, disease-based. We also do a lot with education, so local and national education. We have podcasts, webinars. Our website is a great example of great information. We also do a helpline, which is we have social workers and we have experts who are standing by to help you solve any sort of arthritis-related problem that you might have. And we have events, so ways for you to connect with the community. The Walk to Cure Arthritis is happening all across the country right about now. Also, we have galas like the Bone Bash. We have a big car show in Columbus, which has been going for decades now. And the Jingle Bell Run, we're in our 40th year. And finally, advocacy. You can sign up to help the Arthritis Foundation make sure that our laws are good for people with arthritis and that we're protecting people with arthritis. And you do that by sharing your story. So with that being said, here is my contact information and also my colleagues in Kentucky, Cincinnati, Central Ohio, and Toledo. And you are welcome to call or email us anytime. We're here for you, and we'd love to hear anything that you need help with, and we want to help in whatever way we can. Now I'm going to turn it back to the other presenters.
Thank you, Sandy. Next, Dr. Lackey will be speaking on hip arthritis. Dr. Lackey?
Good evening, and thanks for joining us. As she said, my name is Dr. Lackey, and I am with Midwest Center for Joint Replacement in Indianapolis and Bloomington, Indiana. And at MCJR, we are passionate about taking the pain out of joint replacement for everybody involved, and that is both patients and family members, caretakers, and anyone we come in contact with. And so that was a fantastic introduction about what is arthritis. And I'll get to talk a little bit first about specifically arthritis of the hip, how we manage it, how we diagnose it, and what we do about it. So first, when should you see a specialist such as myself, who's a hip and knee fellowship trained surgeon? You should see one of us anytime you're having a problem with your hip that's interfering with your life. I want to start with an anecdote. A good friend of mine I ran into on the street a couple weeks ago, and he introduced me to his father-in-law who was in town. And his father-in-law found out what I did and told me that he'd been putting off his hip replacement for years and just been miserable, but just didn't want to face the facts and talk about a hip replacement. And I asked him where he hurt, and he actually hurt right on the side of his hip. And it turns out he had bursitis or tendonitis of the hip and could have been living pain-free without surgery 5 years ago when it started hurting. So we'd love to see any of you in our area or any OrthoAlliance surgeon in Indiana and Ohio. We'd love to see you and to help you to get back to the things you love. So specifically hip arthritis, again, arthritis means joint inflammation, but why is the joint inflamed? It is usually because the joint is worn out. That's osteoarthritis, where the cartilage wears off the bone, and is a product of wear and tear, but all humans wear and tear on their joints, but some people are just unfortunately wear out their joints, and that has to do with the genetics of their cartilage, and sometimes in the hip, also the shape of the hip joint and just how we developed. And so I don't know if you can see both hips on the screen, but at least the one hip that's peeking out from my side views of the presenters shows a huge cyst up in the top of the ball and socket joint, and that is definitely a worn out hip, or what we would call bone on bone. And when you're bone on bone or worn out in the joint, most of the time we don't need an MRI. The exam is very simple. We watch you walk and we rotate your hip in and out. And so even if you come in for knee pain, we will very subtly rotate your hip just to make sure we don't miss that, because the hip arthritis can hurt down the front of the thigh and into the knee, which is quite common. So patients never fit into clean categories, but if they did, we would say, hey, if it hurts in your groin or your front pocket, it's probably most likely your hip or down the front of your thigh towards the knee, and sometimes shoots all the way through from front to back of the groin. And that's usually the joint. If it hurts right on the side, that's most often lateral trochanteric pain, or often called bursitis or tendonitis. And then lastly, if it hurts in your low back or back pocket or buttock or down the back of your leg or shooting down your leg, that's most often from your back or pinched nerves in your back. And so we trade a lot of patients back and forth, trying to get them to the right place when they come in thinking they need to sign up for a hip replacement and they really need a back doctor. So most of the time we can see the arthritis on the x-ray like this one, and we don't need to get advanced imaging such as an MRI. Just to mention, of younger patients with hip pain in the groin and in the joint is more often some kind of tear, or can be hip dysplasia, different factors there. And that's often treated differently if the hip is painful but not worn out. So what treatments are available for hip arthritis? We'll talk about this with all joints. And you'll hear, and you probably have heard, as patients with arthritis, you've heard about cortisone shots. we really don't do those a whole lot in a worn out hip. And two reasons. One, it's been shown that if you have a hip replacement within 90 days of a cortisone injection in that same joint, that you have a much higher chance of getting an infection after surgery in that joint. And when people have had cortisone shots in a worn out hip, they often say, yes, it did feel much, much better, but it only lasted for about 3 to 5 days. And we would say, that's really not worth it. What's the 30-year plan about feeling better? We'd like you to feel better a lot more than 5 days. And so, and that all then blocks them out from having a hip replacement. It's very common that when a patient comes in with a worn out knee, ready to talk about a knee replacement, they've been putting up with it for over decades, over 20 years often. And a lot of times it's less than 1 year for a hip. Hips tend to wear out faster and the treatments don't work as well. And it's much poorly tolerated when the hip gets stiff and stops rotating. It's hard to get in and out of the car. It's hard to do most activities. And so patients don't tolerate it as long. Weight loss can help a ton. I had a patient who decided she would lose weight to try to make her hip replacement safer. And when she lost a significant amount of weight, her hip no longer hurt. And she didn't come back to see me for some time. But then life happened and she gained the weight back, and then her hip hurt again, and her body was prohibitive for surgery at that time, though we can do a fair amount of heavier patients. But the key with arthritis for me is that motion is lotion. And we tell patients that the number one thing that you can't, I've got a 7-year-old coming here to help me. He's going to say hi. James, there are hundreds of patients here watching, so we're going to have you go back down with mommy. Sorry about that. So we say motion is lotion. There's nothing better for a joint than motion. And so low impact motion is super helpful. Physical therapy in the hip or knee or anything is great for strengthening the muscles around, but the hip will not start moving with therapy. So it's never curative in hip arthritis. Surgical treatment of the hip is a total hip replacement. The parts, hopefully you can see the slide, all of the slide to the right. At the bottom is an example of a common hip implant. Patients always want to know what the implants are made out of. That is the metal socket and metal stem in the bone is titanium. And the pink ball, yes, it's pink for both men and women. The pink ball is ceramic, and that ceramic ball is made by one company that supplies all the other companies in the country. And then the liner, the white plastic liner, is polyethylene, or a special type of plastic. And we hear every day in the clinic, I was told that hip replacements and knee replacements are good for about 10 years, so I need to just be miserable and put it off as long as I can. And that could not be farther from the truth. We find that patients, the sooner if they are a good candidate and the joint's worn out and they've failed conservative measures, not delaying is very good. Patients get back to life sooner at a higher quality of life and end up living longer as well. Patients that come in and are in a wheelchair because they've been putting it off or didn't know about hip replacement for 5 years have a much harder time regaining the strength and mobility that they've lost. The top right picture is a hip replacement on x-ray. And that's what we would check in the office after surgery at follow-up. The top middle picture shows where an average incision is for an anterior approach to the hip. And that approach has allowed us to use x-ray in surgery, line up the hip perfectly and get the parts in the exact right position, and a little less dissection on the patient, a little quicker recovery, though all of our hip replacement and knee replacement patients, almost all 90% are home in their house the same day as surgery. So what can you expect after surgery? We tell patients there's lots of phases of recovery. The first few days, you're laying low, you're doing some very gentle exercises, you're using ice and taking some pain medicine. Most of our patients are back to a normal day-to-day activity level at 6 weeks. The tissues are not fully done healing for 6 months. Meaning there's lingering tiny bits of pain, but a lot of our patients are walking pretty normally in the first 2 to 4 weeks. But once you're healed up with a hip replacement, we almost never have any restrictions on any of our patients. And we say, you name it, you can do it. If you want to run a marathon, ride a mountain bike, jump on a trampoline, we'll let you do whatever you were doing before your hip wore out, because we want to get you back to doing the things you love. And with that, I'll turn it back to the team for more presentations.
Thank you, Dr. Lackey. Next up is Dr. Byrd, who will speak about knee arthritis. Dr. Byrd? Dr. Byrd, can you share your screen?
Yeah. There we go. All right. Hey, everyone. Thanks for inviting me to speak on knee arthritis. My name is Zack Byrd, and I am an adult reconstruction total hip, total knee surgeon at JIS Orthopedics in New Albany, Ohio. That's right outside of Columbus. And we're going to talk about knee arthritis a little bit. So, so joints in humans are kind of like bearings. You know, we were talking about the hip joint, that's a ball and socket type of a bearing. The knee joint's a little bit different. A lot of people think of it as a hinge, but really it can move about 6 different ways. In this picture, you can see a lot of healthy industrial bearings that look good. There's ball bearings, roller bearings, caster bearings. But, you know, the truth of the matter is sometimes bearings go bad. And if you look at this bearing, it's probably not going to move all that well. And that's kind of the same as what happens in osteoarthritis in the knee. So in the knee, osteoarthritis happens to a lot of people before they actually know they have it. Like Dr. Lackey was saying, there are a lot of people that go from asymptomatic to symptomatic per year, and that's how we know how many people have arthritis. There's about 240 people per 100,000 people per year that become symptomatic. And the reasons that people develop arthritis, there's a lot of things that have to do with overall health picture, like body mass index or the ratio of our height to our weight. Again, increased weight is increased reactive forces on joints, and it tends to make our joints wear out quicker. Glucose intolerance or diabetes, cholesterol, hypertension, risk factors that we can't change, things like gender. Females get knee arthritis more often than males. We get arthritis more as we age, and then genetics. There's not an arthritis gene, but it does tend to be hereditary. So if your parents had arthritis, there's probably a higher chance that you'll have arthritis as well. And then there are things that we can potentially change or improve. Trauma on the joint, even if it's trauma that doesn't necessarily take you to the ER or get you surgery, those micro trauma events that add up over our lives and create internal issues with the knee, like meniscus tears or ligament insufficiency, things like that. Our occupation also plays into this a lot. Heavy lifting, repetitive knee bending, climbing stairs and ladders, things like that can add up over the years and contribute to the osteoarthritis picture. So again, where does osteoarthritis come from? It's kind of a cycle, and it becomes a little bit of a chicken or egg discussion after a while. There's little injuries, little strains, sprains, meniscus tears, ligament problems that add up over time and contribute to arthritis. And then arthritis, because it's an inflammatory condition, also contributes to those other pathologies, sprains, strains. You can exacerbate existing arthritis in the knee, especially with a little tweak or a twist. Meniscus tears can come first, or they can be degenerative, part of the arthritic process, and ligament injuries as well. An ACL tear, for example, could lead to arthritis down the road. Whereas also the degenerative condition of arthritis could lead to ACL deficiency down the road too. So there's a cycle of pathology there. This is an X-ray that juxtaposes a normal knee with an arthritic knee. So on the left side of your screen, you can see a normal knee joint from the front. This is a right knee. So the top bone, the femur, that's the bone in your thigh. And then the bottom bones are the tibia, and the little one is called the fibula. And those are the bones in your leg, in your shin, down below your knee. The kneecap is there. It's sort of hard to see if you don't know what you're looking for, but it's this circle right here in the middle. So the things that I want to point out on this image, first of all, the color of the bone on the x-ray. It's homogeneous and gray. And then second, I would like to point out the space between the bones. It's not that there's nothing there. Cartilage is there. So that's where the bearing actually lives. The cartilage in the knee is invisible to the x-ray. So the x-rays go right through it and it's invisible. And if there's space between the bones, then you can infer that something is holding those bones open. The other thing that I want to point out is the general shape of the bones. They have nice smooth transitions and lines around the edges. And then if we come over here to the right side of the screen, we see a lot of things that are different. So going back to the color of the bone, you see the whitening of the bone. We call this sclerosis. And this is a reaction of the bone to the inflammatory changes in the joint. You can also see that the space between the bones is gone. So you can infer that the cartilage is not there anymore. And that's actually the pathology of knee arthritis. Arthritis isn't something that exists in the joint that you can go in and take out. Arthritis is the loss of something that should be in the joint, like the cartilage. And you can see that the bones are touching here on both sides. You also see that the edges of the bones aren't smooth anymore. They've got a little bit of extra bone here. These little bone spurs are called osteophytes. And these happen, the bone spurs aren't a problem in and of themselves. They're a result of the underlying problem in arthritis. Furthermore, going back to the idea of meniscal tears, if there's supposed to be a meniscus living between these bones, you can also probably infer that it's either gone or torn enough that it's now sticking out the side. And a lot of people notice that as well. The other thing that you notice is in this case, this person's knee has become more knock-kneed over time. We call that a valgus deformity. And arthritis can take a lot of different shapes, but in this case, this person is becoming more knock-kneed over a time as a result of the disease. When should you see a knee arthritis specialist? Well, it's really all about the symptoms. If you've got pain in your knee that limits your function and limits your ability to stand, walk, climb, lift, push, pull, carry, if you've got pain in the knee that keeps you on the couch when you should be out enjoying a sunny day, that's when it's time to see a knee specialist. When it gets really bad, you can have pain at nighttime or pain even when you're at rest. The knee often becomes stiff as a result of the inflammation. The balloon that the knee lives inside of is called a capsule. And if you remember on one of the very first slides, you saw a picture of joints and a little capsule around the joint. So that's the type of thing that the knee lives inside. And as it becomes more inflamed, that capsule thickens and the ligaments thicken, and then the joint becomes stiff. That makes it difficult to navigate environments like uneven terrain or stairs. It also leads to mechanical symptoms like a catching or a locking up of the knee. A lot of times my patients will say if they sit for a little while, then the knee gets really stiff and they've got to limber up before they can really do much. It also leads to an increased fall risk because that pain creates a reflex that then makes the joint want to give way when you're standing on it and it's painful. So what treatments are available for knee arthritis? Well, there's a lot of non-operative treatments. I like to hearken back to something called the AAOS Clinical Practice Guidelines because it does a good job of parsing out what treatments are worthwhile and what treatments may not be. As previously discussed, knee arthritis is typically better tolerated for more time than hip arthritis, and it's not quite as debilitating, but it gets bad in the end. So the clinical practice guidelines most recently updated recommend assistive devices of ambulation like walking sticks, canes, walkers, bracing. There are certain types of braces that can be prescribed for patients if there's a deformity that we're trying to correct. They act to put the weight-bearing axis of the limb through a healthier part of the joint and take the stress off the worst part of the knee. There are topical and oral non-steroidal anti-inflammatories that can be prescribed or even over the counter for you. Exercise, motion is lotion. I usually say movement is medicine, but same basic principle there. Physical therapy can be helpful. If we strengthen and stabilize the muscles around the joint, then we're making the joint not have to work as hard to do its job. Furthermore, it can increase range of motion potentially and help with stiffness. Weight loss, Each pound of your body is somewhere in the 3 to 5 pounds range for each one of your knees. So even a modest loss of weight, 10 pounds, that's like leaving a 40-pound backpack unstrapped in the closet when you wake up in the morning. Education, self-management, activity modification, and then the corticosteroid injection. A lot of people refer to it as cortisone. There are a lot of different names for steroids, and there are a lot of steroids that work well. But a steroid that is injected into the joint is an anti-inflammatory treatment that can help with pain. Do the non-op treatments work? Well, sometimes. A lot of times, if the knee is earlier on in the disease process, they may work better. This is an article that I like that was actually done overseas, and it looks at almost 200 patients with osteoarthritis that were treated non-operatively and followed for 6 years. At the end of that study time, 33% of those patients had elected to proceed with a total knee. If you look at the same article that was written for total hips, it's 2/3 of patients that have elected for surgery. So knee arthritis is a little better tolerated. A total knee replacement is an operation where this is a knee model where we make special cuts on the end of the bone in order to remove that diseased cartilage, and then we resurface it with metal and plastic parts. In the knee, the metallurgy is a little bit different, but we remove the cartilage containing bone and we prepare it to accept the new bearing surface. And on the kneecap, which would be right here, we also resurface the underside of the kneecap with that specialized plastic that we referred to before. Many times, there are a lot of different materials that a knee replacement can be made of, but a lot of times the thigh bone component is made of cobalt chrome, and then the tibial component is made of titanium, and then that special plastic, that polyethylene in the center, is a very wear-resistant plastic. And so after a knee replacement, the day of surgery, we typically do this procedure as an outpatient. Once the patient is able to cross the T's and dot the I's for discharge, they're allowed to leave the center. And on the road home, there are a lot of patients that live right next door, but there's a lot of patients that have to drive a certain ways. We recommend that you get out of the car every hour or so and stretch your legs. Postoperative pain control is managed with a treatment strategy called multimodal pain therapy. And I usually refer to that as the 4 ninjas. So if you think of 4 different ninjas all attacking one enemy from different angles, that's how we manage pain. So we prescribe different pain medications that work together and are stronger together than any one of them by themselves. And that tends to work very well for patients. We also prophylax against blood clots. That's one of the things that we really don't want to have in the postoperative period. So we typically recommend patients walk around their home every 90 minutes. It doesn't have to be a 5K, just a lap around the living room. We also typically prescribe some kind of anticoagulant that's based on the patient's individual profile and their risk stratification. And then we start rehabilitation right away. And there's a lot of different ways that we can offer rehabilitation as well. It could be outpatient physical therapy. We could deliver it virtually. You could use a home exercise program. But then the first 2 to 3 weeks, that's when the pain postoperatively subsides. Patients tend to turn the corner. They de-escalate from those narcotic pain medications. Their wound heals appropriately. They transition from a walker to a cane. And we continue prophylaxing against DVTs. We're progressing in PT. We like to see less than 5 degrees extension and about 90 to 110 at the first follow-up at about 2 weeks. And then within the first 6 weeks, that's when we are off the pain medications. We don't use any canes or walkers anymore. We have a scar instead of a surgical incision. We complete our DVT prophylaxis. Our blood clot medicine is done at that point. We complete physical therapy, and pretty much patients are off to the races, and they can do more or less what they want to do. It's still easy to have a big day at 6 weeks, but it's getting a lot better. And then after the first year, we really hope that there's no pain medications required anymore. The wound is just a scar. There's no canes or walkers. There's no physical therapy. And ideally, you've forgotten that you had surgery and you just live your life pain-free. So then one more note on the survivorship of the toe. So this is the concept that a total knee has a shelf life. I still get a lot of patients that said, well, my primary care doctor says that a knee only lasts 10 years, so I should wait. Well, I don't really know that that's true. If you look at 10 years survivorship data, ubiquitously, universally, everybody who publishes on 10-year total joints has at least 90%, probably closer to 95% of those joints are in and working fine at 10 years. There's about a 1% per year rate of revision surgeries. So one way to look at that is there's a 1 in 5 chance that maybe you've needed a revision in 20 years, but there's a 4 in 5 chance that it's in there working just fine. And I guess I would rhetorically ask, do you want to live now or do you want to live later? Because the knee's going to last either way.
Thank you, Dr. Byrd. Next up, we have Dr. Rolf, who will speak on shoulder arthritis. Are you able to share your screen now, Dr. Rolf, or do we need to pull up the presentation?
It looks like it is. Let's try. I think it's gonna share.
Great.
Maybe it's not. Let's see. It looks like it's not coming over. I apologize for that.
Okay. Matt, do you want to pull up his presentation?
Okay, so as many of you know, hip and knee replacements are extremely popular, well-known. I've been in practice in Cincinnati at Beacon Orthopedics for the last 15 years, and I probably spent my first 7 years educating people that you can actually replace the shoulder and that they actually do well. So what do we know about arthritis? The bad news about arthritis in the shoulder, you can go to the next screen, Matt, is that the cartilage wears down, just like in the knee and the hip. The bones begin to erode. You start developing bone spurs that comes along with pain, stiffness, and decreased mobility. A lot of my patients will say that their shoulder feels ratchety. And over time, these disease and symptoms are going to worsen. Nobody knows what that means. Are you going to progress over 5 years or 20 years like in the knee? No one's really certain. Everyone's different and probably has a lot to do with what they're trying to do in life. Hips and knees are the prime targets. Shoulder replacements are the third. And what do we know? So the good news about arthritis is there's a lot of things we can do. We have better anti-inflammatories than we did 30 years ago. We know that lifestyle modifications can really help you. There's sometimes that if you just stop doing what hurts, you feel better. And then when everything else fails, joint replacements do extremely well in the shoulder, the knee, and the hip. So when you go into the office, what do I need to know as a physician? Number one, I need to know that you're having pain, because it's really hard if you have arthritis and you don't have any pain that I think I'm going to be able to make you better. And so having pain at night, I like to use the subjective shoulder function. So what that means is how close to normal are you? And I use this a lot with people who've done both shoulders. If your shoulder is 20% normal and I make you 80% normal, you tend to be very happy. But if your other shoulder is 60% normal and I make you 80% normal, you don't get the same response. So I try to tell people you really want to make sure your pain is the reason that you're having that shoulder replacement. On physical exam, you'll have restricted motion. I need to make sure you have an intact rotator cuff for an anatomic shoulder. And if you don't, there's a different type of shoulder replacement we'll do. And then I need x-rays that show that you have shoulder arthritis. But more importantly, I can't forget the other things. There's a lot of crossover between a pinched nerve in the neck and the shoulder. So if we look at x-rays, you can see the difference between the x-ray on the left versus the right. You're going to get irregularity from the osteophytes or bone spurs. You're going to get subchondral cysts. You're going to get joint space narrowing. And these are the radiographic hallmarks of arthritis. So when you come into the office, the goals of treatment for arthritis, and this really goes with any joint. Number one, we want to control the pain and other symptoms that are caused by the disease. Number two, We want to optimize your function. And most importantly, we need to educate you on what's going on. I think that when you understand what your problem is and what your options are, you're able to make an informed decision on how you want to proceed. So temporarily, we can do things like anti-inflammatories. Occasionally, injections will work. If you have an inflammatory arthropathy like rheumatoid arthritis, the medicines they have for that are life-changing. And there are probably more people with rheumatoid arthritis that we don't pick up in the office because we just don't see it like we did 30 years ago, where maybe 40% of our practice was rheumatoid arthritis. Getting a good night's sleep will help with your pain. Good cardiovascular conditioning will help with your pain. And then different orthobiologics, whether it's PRP or stem cell, have been used, but the data is just not there when it comes to shoulder arthritis. So when should you consider surgery? Just like with the hip or knee, when the non-operative treatments are no longer working, you cannot do everyday activities. They become extremely difficult. You can't sleep at night. You've tried the non-surgical solutions and have little pain relief. And then even sometimes maybe anti-inflammatories really work, but we have a lot of patients that can't tolerate anti-inflammatories. And those are people that may progress on to surgery. So the shoulder replacement, there's two main types. One is an anatomic shoulder replacement. And if you look at these three different pictures, it really looks like the X-ray did. You're going to have the glenoid socket, which is replaced with a plastic cup that's glued into the bone. And then on the humeral head, you're going to replace that with a metal prosthesis. That can be a stemless prosthesis, or that can be a stemmed prosthesis. The other type of replacement that you will read about on the internet is a reverse shoulder. And in fact, shoulder replacement is one of the fastest growing replacements. And a lot of it has to do with the reverse shoulder. If you look at that X-ray on the left, it just looks different than what we've seen so far. That humeral head is a little bit higher, and it's abutting the acromion. We call that a high riding humeral head. And the reason that's happening is because the rotator cuff is deficient. It's not doing its job. Usually when the rotator cuff is doing its job, it keeps that ball centered in the socket. And as a result of this deficient shoulder, there's a high riding humeral head. And sometimes when this happens, you will have the inability to lift your arm up, almost like you're paralyzed. We call that pseudo-paralytic. It's not that you're not, you usually have full passive range of motion, but you just don't have the strength with the muscles around your shoulder to lift your arm up. So by switching the anatomy, if you look at the X-ray on the right side, you'll notice that there is a ball now on the socket, and the stem doesn't have that ball in it. So it's a ball and socket, but it's reversed. So we call it a reverse shoulder arthroplasty. Most shoulder physicians, this is about 55 to 60% of the replacements that they're doing because of the population that has rotator cuff arthritis. So shoulder replacements are successful. As I mentioned, they're the third most common. Historically, they had shorter hospitalizations. I actually do most of them as an outpatient. I was one of the first in our group to do joint replacements as an outpatient with the shoulders. Really, there's probably over 100,000 shoulder replacements. I've seen numbers as high as 150, and it's growing at a rate of 20 to 30% per year annually in the United States. So these are two patients, and I always like to show this because I just want you to get an idea of which shoulder I did. And really, if you can get that one on the right to move to, Matt, they had both shoulders done. So they have quite a bit of their motion back, near full range of motion. They're extremely functional with these shoulders. And most importantly to these gentlemen, they no longer have pain and can enjoy their life. There are risks involved anytime you do a joint replacement. Fortunately, with shoulder replacements, bleeding is not very high. I've never transfused a shoulder replacement. Whenever you talk about infection in a joint, that's catastrophic. Fortunately, it's not high, but when it does happen, because those implants don't have a blood supply, they can be life-changing and really can take a year or two to recover from. Historically, in shoulders, you would get wear in the glenoid socket. We now have new polyethylenes that do much better. We used to historically glue our implants in, and when that bone cement bone interface was disrupted, bone did not have a great way to grow back into the implant. Now we have a way for bone to grow into some of the new modular implants that have special metals around them. You rarely see instability anymore. Just like a regular shoulder, you can still tear your rotator cuff. Just because you have a replacement does not mean you're immune to rotator cuff tears. But by and large, these complications are extremely low. If you ask these are just with my patients, 98% of the patients are happy they had their shoulder replacement, would do it again. And interestingly, 97% of their patients will say that their shoulder is greater than 80% normal. And actually 35% of my patients rate their shoulder as normal. I know it's not a normal shoulder, but the benefit I have is they've had such a bad shoulder for so long that they forget what a normal shoulder is. It's very different than my rotator cuff patients that may have tore their rotator cuff in the last 2 to 3 months. Most of them remember what their shoulder was. And even though we make them better, we may not make them as good as they were. They have a very different experience than our shoulder replacement patients do. So if you look at some of the scores, I like to keep functional outcome scores with my patients. This just gives you an idea of 100 is the highest score with a normal shoulder. And it gives you an idea of where people are preoperatively with a regular glenohumeral osteoarthritis. At 2 years, they go from a score of 38 up to 92. And if you look at reverse shoulder, although similar, these are lower demand patients usually, they go from a pre-op score of 32 to 81 at 2 years. So these do extremely well. Most of these are inpatient. I mean, outpatient, I tend to do about 90 to 95% of my shoulders as an outpatient. Sometimes there are medical issues that necessitate doing this in a hospital. Also, as we get to be a little bit more mature and you get to be 80, 85, I feel like your body's going to respond differently. And this might be one that we just watch you overnight in a hospital, or at least we do it in a hospital to see how you tolerate the surgery. Regardless of where you do it, the experience is the same. We'd use the same infection prevention measures. You'll use a lot of nerve blocks for pain control. And we tend to have experienced surgical staff that are part of every surgery that I do. These are people that have done hundreds of these with me over the years. Postoperative pain control is important, just like they do up in Columbus. We try to do a multi-modality approach. Anti-inflammatories, we tend to do a nerve block. The nerve blocks typically can last up to 3 days. They average 55 hours. My experience is then 80% of patients are usually just taking Tylenol at 3 to 5 days postoperatively. So very few people need narcotics after shoulder replacement. Post-op physical therapy is important. It's important because it helps you regain your range of motion and your strength. Range of motion is going to start right away. It's also important because it's hard to get around with just one arm. And there's some tricks that they can show you to help you get dressed and help you function in life. Typically lasts up to 12 weeks, sometimes a little bit longer. And you tend to have more visits at the beginning. Really, the better you're going to do with physical therapy, the less visits you'll have. Just for some expectations, I tend to do a sling for about 2 weeks. I try not to have you lift more than 5 pounds, which is about half a gallon of milk, until 3 months, 10 pounds from 3 months to 6 months. And then 6 months, you really can do whatever you want. I always tell patients with a regular shoulder not to lift over 50 pounds overhead, although I know there are physicians around the country that will give patients no restrictions. And I know I have patients that don't necessarily follow the rules and lift whatever they want. But I think, our goal is to help make this last as long as possible. They tend to last about 15 to 20 years. They're very similar to knee replacement with a failure rate of less than 1% per year. I tend to do x-rays yearly up to 2 years, and then every 5 years thereafter. I only recommend antibiotics for dental work for the first year after surgery.
Thank you, Dr. Rolf. Our next speaker is Dr. Philbin. He'll talk about ankle arthritis. Dr. Philbin?
Good evening, everybody. Let's see if I can get this to work there. All right, looks like we have my talk there. So thank you, everyone. Thanks everybody for tuning in tonight for this educational event. We've now heard about shoulders. We've heard about hips and knees. Now we're going to move down the stream a little bit to the ankle. And so I'm going to talk about ankle arthritis. How do we know when we have ankle arthritis? When do we know to see a specialist, and what are some treatment options? Okay, it's just, I'm not advancing here. There we go. So really quick, just want to talk about our group that's part of the OrthoAlliance partners. Our group is the Orthopedic Foot and Ankle Center. It's in Columbus, Ohio. It's the first practice to specialize 100% in foot and ankle. So that's really all we do. We have offices in Worthington, Dublin, Gahanna, Grove City, and Zanesville, just all in Central Ohio. We have in-house PT that's part of the OrthoAlliance physical therapy network that's really throughout really throughout Central Ohio and beyond, which is great for patients and convenience. We have an in-house MRI that just does foot and ankle, so it's the foot only goes in. We have weight-bearing CAT scan. We actually have a store to help with any of our patient needs. We're dedicated to education. We train residents. We have fellows every year, and we're dedicated to research. And 3 of our physicians are basically help design some of the current total ankle replacement designs that are FDA approved. So when we look at ankle arthritis, a little bit different some of the other joints that we heard about, from the standpoint that, yes, people will have primary ankle arthritis, the wear and tear. They'll have inflammatory, which includes rheumatoid arthritis, but post-traumatic by far in the ankle is the most common. So these are people that have had fractures, have had traumatic episodes, have had long-standing ankle instability. So that's going to be the most common patient that we're seeing for ankle arthritis. When do you know that you need to see a specialist? Well, when you start having these symptoms, that's probably when you need to do it. So if you're taking less steps, you're avoiding doing things, it's interfering with activities, you slow your walking speed, you basically have diminished ankle push-off. And when your stiffness and your pain alters your gait, it can affect the entire chain. So it can start to bother, not only your ankle, other parts of your foot, your knee, your hip, all the way up the chain, just because of how altered your biomechanics are. And from a physical impairment, it's actually interesting. There's been studies that have shown for ankle arthritis that it can actually equal some of the major medical disorders that have impairments, such as end-stage renal disease and congestive heart failure. So how do patients present? Typically, they're going to have pain, usually worse with weight bearing and activity, stiffness, perhaps worse in the morning. They're going to feel like they're losing motion, and they'll have crepitation, which basically is popping almost like Rice Krispies in the front of your ankle, and you'll see this a lot of times in the joint. When you come to see us, one of the things we want to do is we want to try to understand what activities aggravate your pain, which things make it worse, which things make it better, and try to exactly pinpoint where your symptoms are. So when you're in the office, we're gonna check everything. We're gonna look at the front of your ankle, the back of the ankle, ligaments and tendons, but also make sure that it is the ankle that's the issue and not other joints, like one of the most common joints called the subtalar joint, which is right below your ankle. We're gonna assess your range of motion or lack of motion. X-rays are going to be really important. We've kind of heard this from everybody. Weight-bearing X-rays are going to be really, really important. And if you look here on this X-ray, we heard this from everybody, but you can't see cartilage. You see the space where the cartilage lives. And if there's no space, there's no cartilage. And that's essentially what arthritis is. So if you look over here, you can basically see on the joint here on the right that there's very little joint space. And that just means that basically the cushion has been lost between the joint. As far as CAT scan can be an important thing to really help us understand deformity, understand which joints are most affected. And we offer a weight-bearing CAT scan, to my knowledge, is one of the only in Central Ohio. And it's great because it's great for preoperative planning. It helps us to look at arthritis in 2 and 3 dimensions. And for the kind of ankle replacement I use, it's a patient-specific one. The weight-bearing CAT scan is very important. Other things to look at, MRIs. MRIs are going to show us more soft tissue. They're going to show us cartilage, ligament, and tendons, and things like that. So we've heard this before, same thing in the foot. What are our goals? Relieve pain, prevent further deformity, and try to improve function. When we look at some of the list of treatment, basically we've heard about different medication, anti-inflammatories. We're going to talk about some bracing. There are different injections. There are PRP injections, unfortunately, usually not covered by insurance and can be expensive. The other thing that's out there is doing steroid injections. Again, it's something that can buy you some time, but it's not really a cure. And when we look at visosupplementation, this is something that there's some studies in knee that are favorable, others that are not. But the bottom line is it's not really an option in the ankle because it's not FDA approved for the ankle. When we look at bracing, this is a kind of a brace we call an AFO, an ankle foot orthosis. It can be helpful in the right patient. Another potential brace is this one here. It's a lace-up brace that's actually custom. It's called an Arizona brace. When it comes to bracing, it can certainly be an alternative to surgery, but it's probably best reserved for an older, more sedentary population from just a tolerability standpoint. When we look at surgical things, there's a lot of different things that can be done. We can go in arthroscopically, remove spurs, clean out the joint. It's definitely not a cure for arthritis because, as we heard, there is no real cure. And these are for people that have low grade arthritis. The surgical options for end-stage arthritis are going to be ankle arthrodesis, otherwise known as fusion, and also an ankle arthroplasty. A lot of people say, well, I didn't know you replace ankles. And it is something we do. And we're really in the 3rd and 4th generation, and the results continue to increase year by year. So ankle fusion is a good operation. It's stood the test of time. It's been around since the early 1900s. People can do very well, again, in the right patient. Basically, people get, sometimes they get freaked out when you say you're going to fuse the joint, and they're like, well, how am I going to walk? Well, what you have to understand is that when you have end-stage arthritis, you've lost most of your functional motion, and it's the motion that's left that's a pain producer. So they can do quite well. One of the downsides to having a fusion is that the joints that are just around that area usually will take on more wear and tear, and those things can eventually lead to arthritis, potentially requiring other treatments in the future. So obviously you're going to lose that motion, but some people still may have up to 40 to 50% of dorsiflexion, which is actually coming from a different joint. They'll lose about 16% of their walking speed, and overall they will consume a little bit extra energy after having a fusion. What about ankle replacement? If you look generally at the outcomes compared to a fusion, most of the literature shows that the range of motion and gait is going to be better in total ankle patients compared to fusions. But basically, it still can't say that it's really normal range of motion. The indications for this, patient selection is key. You want to make sure that your patient's expectation meet your expectations. It's not something that's for everybody. Generally speaking, we want to do it in people that are 50 and older because, like we've heard with the other joints, they do not last forever. We sometimes want to consider this in more low demand people. And what I mean by that is if you're somebody that's lifting a lot of heavy weight, if you're someone that's on ladders, someone that's on a telephone pole, for example, this is someone that's maybe too high demand to consider an ankle replacement. And then we want to avoid people that have excessive weight. Things to avoid in a total ankle replacement, people that have a thing called talar AVN or avascular necrosis, which basically means bone death or lack of blood supply to the bone. People that have neurologic compromise or neuropathy, people that have had infections, and people that are generally weigh more than 300 pounds. So again, looking at the literature, if you look at some of the early things in the first 3 to 6 years, 70 to 90% survivorship, and now getting in 8 to 10 years, 80 to 95. I have many patients in my practice that have had a total ankle replacement in for anywhere between 10 to 20 years and are still progressing well at this time. So I'm going to go over some quick little cases here just to kind of illustrate some things. So this is a 52-year-old female with a history of a pilon fracture, which is basically a fracture at the end of the tibia that affected the joint. And even though this is put together very well, sometimes you just can't really save the joint and people end up getting arthritis. So here's what her ankle looks like about 6 months after surgery. You can see a lot of the space that she has in that area. And then if we fast forward to 1 year and 7 months, again, looking at things. And ultimately, about that time frame, one of her goals was to get back and try to do a half marathon. She was able to return back to a half marathon. She walked and ran it. It wasn't a full run, but she was able to do it. And it's something that she simply could not have done prior to surgery. Another quick case, 62-year-old failed bracing in the past and steroid injection. You can see there in the x-ray, very little joint space. Subsequently had surgery. If you look at this video, basically, you almost can't even tell which ankle has been replaced because the gait looks so good. And this patient has been very pleased, and he's probably at this point about 2 years out. Just another quick view, again, showing the motion that the patient has, and it's good free range of motion. And again, illustrating that, ankle replacements do exist and they can do very well. As far as after surgery, what to expect, most patients are non-weight bearing for about a month, and then for another month, they're in a boot and they start therapy. We like to get therapy going as quickly as we can. We really can't do it in the foot and ankle until, we have good soft tissue healing, and that the swelling is starting to come down, but, non-weight bearing for a month, and then typically in a boot for a month, and then progressing there. And most of our studies show that people continue to improve even up to a year or 2 years after the surgery. The big question is, what activities can they do? And so, one study has showed that after patients have had a total ankle replacement, that 65% were able to get back to doing increased sports activities. One study showed a lot of those patients do light reaction and non-impact sports. Another study basically showed that before surgery, they were about 36% active, and then after about 56% active. And some of the things that they're doing are like hiking, biking, and swimming. And then another recent study that basically looked at people getting back to pickleball, which is a huge thing nowadays. And the majority of patients were able to get back to pickleball at a very high level. That is all I have this evening.
Thank you, Dr. Philbin. We have a few questions now. The first question is for Sandy. What types of missions does the Arthritis Foundation participate? Oh, just a second. I lost it. What types of missions does the Arthritis Foundation participate in, and how can members of the community get involved?
So every market is different, but basically, I'm going to talk about Indiana, and you're going to need to reach out to your local representatives because we're all doing slightly different stuff. Here in Indiana, we have 2 different mission programs that we focus on. One is juvenile arthritis programming and support. We have a committee of people who get together to put on fun activities and educational activities for families, and also just increase and improve our outreach to those families. And the other one that we do here in Indiana is what we call the Live Yes Toolkit series, and that is an educational series that we do for underserved folks in central Indiana to try to bring education to folks who may not be able to otherwise access it, and we work with community centers. But since everybody is doing something a little bit different, I do recommend that you reach out to the people in your local office who can get you hooked up with mission volunteering activities. There's also, I should mention, boards, leadership boards that are helping to advance the mission in all sorts of ways.
Thanks, Sandy. The next question is, why do females have a higher incidence of arthritis in the knee?
This is Dr. Byrd again. I don't see myself on the screen, but I'll take that one. So I can think of like maybe 6 reasons. So number one, menopause is a big reason why, and I think that menopause is actually, if you look at the incidence of arthritis in the knee at approximately 50 to 65 years old, 50 and older, about 1/3 of women have arthritis in the knee, and about 1/5 of men do. So that's like 35% versus about 20%. And one reason is because of changes in hormones. So hormones earlier in life can be protective against arthritis, and as they change, then that protective effect can go away, essentially. And another reason is because women tend to be quad dominant, meaning the muscles in the leg, in the front, in the thigh, the quadriceps. Women have stronger quadriceps compared to the muscles in the back, like the hamstrings, and that changes the joint reactive forces, and it also makes them susceptible to things like ACL tears. So ACL tear is a good way to get arthritis later in life. Remember the little cyclical circle of the knee arthritis thing. Another reason is joint elasticity. Women tend to have more elastic joints than men do, especially in relation to gestation and postpartum type situations. And that joint elasticity can lead to micro instability, and micro instability is kind of that additive small subclinical injury over the years. Limb geometry. So women tend to have a shorter leg than a man and a wider hip than a man, and everybody's legs do a little bit of it's normal for your knees to be about 5 degrees knock-kneed, and that's what people see as a straight knee. And in women, that angle can increase a little bit, and that puts more pressure on the joint between the kneecap and the thigh bone. And it can also, it again changes the joint reactive forces, and it can overload the lateral side of the knee and the patellofemoral, the part of the knee that the kneecap and the thigh bone where they come together. There's some new research out that suggests that maybe there's a genetic difference between men and women with respect to the composition of the meniscus. And the meniscus acts like a shock absorber inside the knee. So if there's a little bit of a susceptibility to meniscal damage in women, then that means that their shocks go bad a little bit quicker than men do. After menopause, women are a little bit more prone to obesity than men are, and obesity is a risk factor for arthritis. And then the other thing, we didn't really hit real big on rheumatoid arthritis, but rheumatoid arthritis is a reason to have arthritis as well. And that's more common in women as well, because they tend to have a more inflammatory profile, and their immune systems tend to react a little bit stronger to viruses, immunizations, environmental factors. And that inflammatory response, the inflammation, can lead to more arthritis.
Thank you. The next question is, do partial knee replacements last as long as a total knee?
That's a
Jump in
great
on that one.
That is a great
Go ahead.
question. Yeah, whoever can take it. You want to take it, Dr. Lackey?
Sure, I'm happy to. So we do, as the JIS guys do, we in Indianapolis do a whole lot of partial knee replacements. And our algorithm for that, we would somewhat jokingly say, why would you cut out 2/3 of a normal knee if only one of the 3 areas of the knee is worn out? Of all the risks of joint replacement, partial or total, the chance that the implant wears out when nothing else is wrong with it is almost unheard of. And so the survivorship that we see in partial knees and total knees, we say, hey, what's the chance if the right patient has the right operation, partial knee or total knee, what's the chance I have one operation and no one's operated on it again? When we check in with everybody at 20 years, we'd say that's about 9 out of 10 patients have not had that joint redone. And so for us, less is more. And if you're a good candidate for a partial knee, then that's a great option. If the whole joint's worn out, then that's kind of off the table and that ship has sailed.
Can I add into the partial knee discussion?
Please.
Please.
Okay, great. So I think that your approach and everything you just said is great, and I agree with all of it. One of the things that I discuss with my patients when we're talking about a partial knee is, a total knee is not necessarily ever the wrong answer, but a partial knee could potentially be the wrong answer in the wrong patient. So if you get a partial knee and you really needed a total knee, then that is grounds for an early revision. So we always have a discussion about the possibility that in the OR, we find that a total knee would be better. So maybe we switch gears intraoperatively and really do a total knee. That doesn't happen often, but it happens enough to mention it. When we do partial knee replacements, we do that as a definitive surgery. We don't do it with the intent of ever replacing it again. And someone who's a good candidate for a partial knee, that surgery is definitive. Now, if you look at registry data, what that means is data where all of the procedures in the country are looked at all together to figure out how well they work, essentially. Partial knees have a little bit of a higher revision rate. So I shared registry data in my presentation about total knee replacement, and the survivorship at 10 years for a partial knee replacement is a little closer to 80%. But there's a lot of reasons for that aren't necessarily that a partial knee is a bad surgery or doesn't last. Like Dr. Lackey said, if you only are replacing one part of the knee, then that leaves other parts of the knee for other surgeons potentially, or other things potentially to go wrong. And they may need, just because you have a partial knee replacement doesn't mean that you couldn't later develop arthritis that you didn't have before. And it doesn't mean that you couldn't tear the meniscus that's still left in the knee or your ACL. So there's a lot of reasons why you could need that revised that don't really have a whole lot to do with whether or not the partial knee will last.
Can the foot and ankle guy
Of course.
make a quick thing? So this is more as a patient and not as a doctor, but I had a partial knee done about 5 years ago from one of the surgeons I trained with a million years ago that's at JIS. And so I'm 5 years into it, and by and large, I love it, and it's doing great. So that's more as not a surgeon, but as a patient.
Yeah, thanks for throwing that in there. It's good.
Great. Our next question is, if my knees have worn and hurt to the point of needing a replacement, but I need to lose 50 or 60 pounds first, do you help me with that or offer weight loss drugs? I'm struggling.
So this is also a really good question, and this is a point of contention in the arthroplasty community at our national meetings and everything. There's always debates about this topic, and obesity increases the risk of complications, but it depends how you read the statistics, and it depends what you do about it. So let's say that you've gone to an institution and they say, oh, we can't operate on you if your BMI is over, X. And then they say you need to lose 100 pounds. Well, if you do that in a way that's unhealthy for your body, it could result in a malnourished state. And there's plenty of data out there to suggest that a malnourished state has just as many, if not more, complications associated with that. So it's a slippery slope. Some institutions require a certain BMI. At JIS Orthopedics, we don't. It's an individual discussion. It's an individual patient, individual risk profile. Everything's risk stratified. We don't currently offer weight loss drugs, but we are looking right now at potentially starting to open a GLP-1, we're looking at opening a clinic to help patients with that right now.
Thank you. Any additional questions? I think we might have one coming in. Just a moment. No additional questions?
Can I ask a question?
Yes, of course.
This question is for Dr. Philbin. So back when I was training a while ago, there was you kind of touched on this. There was a thought that for a laborer or someone who is a higher demand, as you put it, that the ankle fusion is a better operation. Can you get a little bit more granular with where ankle replacements have come in the last, say, decade, and what types of activities those patients can really get away with?
Sure. I mean, I think some of it, some of how we do this is going to be, it's going to be surgeon thinking, as to what they're comfortable with. But I think that, if you have somebody that's super heavy labor intensive, that carry a lot of heavy things, they're on a roof, they have, things like that. I talked about, the guy that's on a telephone pole. Those are people that may be better off, avoiding a replacement just for the risk of, wearing out over time. And, the difference between the ankle and other joints is it's a very that the surface area is different. It all kind of goes one defocal area. I think a lot of it has to do how much deformity do they have going in. If I have someone that has very limited deformity, and I'd probably be more apt to let them, and we get it, and everything goes well, and I'd be more apt to letting them go back to more higher demand things than maybe I would have 5 to 10 years ago. But I think that a lot of things we've learned with total ankles really are go back to looking some of the old hip and knee literature, and we've learned from a lot of those things. And I think as things continue to get better, I think we're letting people do more things. In the past, I would have never let a patient do any running. I can't guarantee that somebody's going to be able to get back to that, but I think it just depends on, it's not a straight answer. It's what are they doing? What's their body habitus? Do they have a deformity? And then ultimately, setting your expectations, the patient expectations. So I don't know if that actually answers your question, but I think that's what it comes down to.
Thank you. We have a couple other questions. Can revisions be made to shoulder replacements if the patient is much younger than 50? Or is it one and done?
It's certainly not one and done, but it really depends on the type of shoulder replacement you had. And a lot of times, if you had an anatomic shoulder replacement, and the way you go in there to replace that is go through the front rotator cuff and take that down, the more times you go through that front rotator cuff, the more likely it is to become incompetent and not heal. And so you may have to convert from an anatomic to a reverse shoulder. When reverse shoulders first came out, we didn't really know how long they were going to last. They were approved in 2004. We thought they might last 6 to 7 years. We thought that was our ace in our back pocket. I think with some of the newer systems, some of the newer techniques that we have, we're now able to revise those with very few exceptions where we might not have a suitable alternative for revision. So you're absolutely right. When you're young, and I've certainly replaced patients in their 30s and 20s, if it's the right thing to do, we have long conversations about their potential need for future surgery. And I really stress the need to follow through with restrictions and weight limitations just to try to help that primary or index procedure last as long as possible.
Thank you. When I hear some people say that they are back to work and walking in 4 weeks after knee surgery, and some much longer, the whole thing scares me.
Is it,
Yeah,
is this me or
recovery.
you want to take it, Dr. Lackey?
Either one.
Go for it.
I'll jump in. Yeah, it's super patient dependent. The example I use with patients for myself, which may be TMI, is the time I had a kidney stone, I had zero pain. And that didn't mean I was tough. It didn't mean I just handle pain better. I couldn't feel it. There was no pain, none at all, no feeling. And so it is very different. And even side to side on the same patient, when we do say, a knee months apart, they'll say, hey, what did you do different this time? It didn't hurt nearly as bad. And we say, we did it exactly the same way we did the last 5,000. I'm not sure. And so, yeah, we'll have a patient that'll send us a picture on a mountain bike on a trail 3 weeks after a hip replacement. And then we'll have and that's not normal. And then we will have a patient that's like, man, it really caused pretty severe pain for the first 3 months. No one's totally done healing for 6 months, at least, maybe even a year sometimes, but everybody's different. And the goal and that we're always shooting for is a quicker recovery. But what I do tell patients is, hey, the pain that you go through from surgery, whether it's, some people say it was a lot, some people say it wasn't a lot, is worth it, because what we care about is the 30-year outcome from the joint replacement. And if it took you 2 weeks or 6 weeks or 8 weeks or 12 weeks, that doesn't matter if you can live pain-free for the rest of your life, which is the goal.
Thank you. The next question is, I still have nerve pain 10 months post total knee replacement. Why and how common is this?
Well, this sounds like a question that is honestly probably best answered in the clinic. I can't say that I see a lot of nerve pain after total knee replacement myself, but at the same time, everybody gets a little numb spot beside their incision. I think that to answer that question, you need a hip or knee specialist to put their hands on you and talk through it and evaluate your symptoms a little more. So I might make an appointment with someone who you'd like to see and get that checked out.
Thank you. Can you talk about the advancements with shoulder replacements, specifically 3D printing?
Yeah, so there's a lot of things that are coming down the pipe with shoulder replacements, including robotic. And one thing you have to remember is you still have to be a good surgeon. You still have to do the exposure, and robot or 3D printing doesn't make a bad surgeon better. But what 3D printing does is it maps the anatomy, the bony anatomy, the socket, and now the humerus. And on the computer preoperatively, I can try to maximize exactly how I want to replace the shoulder. And then the 3D model that I get intraoperatively helps me reproduce that let me be a better surgeon with that particular patient. And I think the first robotic shoulder was just put in a couple weeks ago up at Mayo Clinic. And I think they're going to make us be better. But again, you still need to be able to do the exposure and get down to the socket, which is one of the more difficult things in the shoulder. But I think they're gonna make our better surgeons even better.
And the final question for this evening is, can an individual be too old to get a replacement on any of their hip, knee, ankle, or shoulder?
I maybe can start off and try tackling that one, and then others can jump in. But I think too old. I think a lot of it depends. It's not really what someone's actual age is. It's how active they are, how healthy they are. And I'll basically use two examples. My aunt in Chicago, who at the time was in her late 80s, still pretty active. She was going to have a surgery to her ankle, a replacement to her ankle, and she saw me as a second opinion. And she's, slowing down, not as active as she was. And we got her a brace, and she never ended up having to have surgery and loved it. So again, brace is a good option in that situation. And as our patients get older, sometimes the risk can be higher. Another example is I recently had a patient in their late 80s who were unbelievably healthy, extremely active, does a lot of things, and so we did all the steps to make sure that they were cleared surgically. I mean, the woman literally had no history of anything. And so even though she was in her late 80s, she was still a great candidate because she was healthy. It was interfering with her life, and we were doing it for the right reasons. I think it's not just the age. I think it's the health of the patient. Are they motivated to do the recovery? Can they stay off of, in a foot and ankle, can they stay off of their ankle? Can they be on crutches? Do they have someone to help? And those kind of things. Those are all the kind of things that are going to enable people to be able to do it. Whereas, if they can't stay off of it because, they can't have enough upper body strength, then maybe they're not a good candidate for surgery. And if their health is not great, they're probably not too old, but just not healthy enough to have surgery of a replacement of this kind.
Yeah, I would echo that. I mean, I see a lot of farmers out in Batesville that are still farming in their 80s and 90s. And I once did a 92-year-old who had a tremendous outcome with her shoulder. And she said, "Oh, I'm going to send my brother to you because he's been having shoulder pain. He's 84. I said, "Oh, he's your younger brother." She goes, "Oh, wait, no, he's 94. He was her older brother. And he came and he's had both of his shoulders replaced and has done tremendously well." But on the other side, there are some 60-year-olds that come in that have a lot of medical comorbidities and just are not great surgical candidates. So you see the spectrum on both sides.
Any additional comments? Great. Thank you for participating in tonight's webinar. The next webinar in our series of Overcoming Arthritis will be held on Wednesday, May 15th. Doctors John Martin, Greg Sarkisian, Scott Stevens, and Adam Miller will be speaking on arthritis of the hip, knee, shoulder, and ankle. You can register for our upcoming webinars at orthoalliance.com/events. Thank you very much to all of our speakers, and thank you to all of our participants, and good night.
Thank you.
Thank you. Good
Good
night.
night, everybody.
Go Pacers.